daughters and fellow DVMs. So today we are going to present about update on anal sacculitis in a German Shepherd dog. Again, meet Hagen or Kyle, a 10 years old male German Shepherd. Initially, the body weight was 33.4 kg and now reduced to 31.8 kg throughout the hospitalization. This dog was belonged to PDRM and being fed with cable. The latest diagnosis was recurrent bilateral anal sacculitis. This is the problem list when we took over the case on 25 October 2021. Hagen had wound at bilateral anal sac caused by the rupture of anal gland caused by anal sacculitis. So plan for this problem, we just do daily wound cleaning using diluted Hebe scrub and iodine, followed by topical antibiotic cream. The second problem was pyrexia. It can be caused by bacterial infection from the open wound or blood parasites such as E. canis and babesiosis. So we decided to repeat CBC and serum biochemistry. We've sent blood samples to parasitology lab to check for blood parasite. Hagen developed another problem under our care, which was bilateral false malign ear discharge that could be caused by bacterial infection, such as Staphylococcus, Streptococcus, and E. coli. Or it also can be caused by fungal infections, such as Malassezia. For this, we decided to do ear swab cytology along with ear cleaning. So for the problem number 1, wound at the bilateral anal sac. This is the latest progression of the wound. On day 7, there was 2.5 centimeter depth wound on the right anal gland. However, on day 21, which is last day of our rotation, the left pocket was closed and right pocket just left with 1 centimeter depth wound only. The wound was healing very well with good granulation tissue without any necrotic tissue was found throughout the rotation. So we do follow up the result for the bacterial culture and AST. The swab sample taken from the ruptured anal gland was sent to the bacteriology lab and they managed to isolate Proteus mirabilis, E. coli and Enterobacter. Previously, this dog was treated with 2 antibiotics, which is metronidazole and also cefalexin. However, based on the AST test, those 3 bacteria were found to be resistant to these 2 antibiotics. So we do also follow up for the histopathology result. The histopathological finding was moderate inflammatory infiltrate composed of lymphocyte and plasma cell with dense granulation tissue with the histopathological diagnosis of chronic lymphoplasmacytic anal sacculitis. Hagen still developed pyrexia under our care despite of treatment, so we put it as our second problem. This is the blood result a week before we handled the case, which is on 18 October as compared to when we handled the case, which is on 25 October. As you can see, this dog got normocytic normal commit regenerative anemia and the PCV dropped from 31% to 29%. For the leukogram, previously Hagen got marked leukocytosis with marked left shift neutrophilia, monocytosis, and eosinophilia. However, when we repeat the CBC on 25 October, all parameters went back to normal already. For the serum biochemistry, we found that Hagen got mild elevation, mild hyperkalemia due to dehydration, and got low creatinine level due to reduced muscle mass. And Hagen got hypoalbuminemia due to inhabitants and also mild hyperglobulinemia might be due to inflammation or infection. Previously, SNAP4DX test was done on 13 October, which is day of hospitalization, and the SNAP4DX result was negative for all.
On 27th of October, blood was sent to parasitology lab to test for blood parasites such as E. canis and babesiosis, and the result came out all negative. So this is the blood smear done on 27th of October. There's predominant echinocytes, which just indicate a drying artifact. So this is the progression for the pyrexia. Agent had normal temperature until up to Thursday, which is on day 11 of hospitalization, which Agent was found to be pyrexic about 40.4 to 40.8 degrees Celsius throughout the day from Thursday to Monday. And so doxycycline was started on the next day, on Tuesday, and the pyrexia was resolved 24 hours after starting doxycycline. The blood result just now was done on Monday, 18th of October and Monday, 25th of October. So problem number 3, foul smelling ear discharge. We did an ear swab cytology and we found that there's numerous rot and cocci bacteria and no malassezia organism is detected. So for the updated problem list, we can rule out babesiosis and the malassezia fungal infection. As for the treatment of anal sacculitis, wound cleaning was done twice a day with normal saline diluted Hibis scrub, diluted povidone iodine, gentamicin cream, and Wouncerex. Cephalexin, 15 mg per kg, 1 tab per os BID was given from day 1 to day 21 as broad-spectrum antibiotic. Metronidazole, 10 mg per kg, 1 tab per os BID was given from day 1 to day 15 as antibiotic for anaerobic bacteria. Serratiopeptidase was given 1 tab per os BID from day 1 to day 21 as anti-inflammatory. Tramadol 3 mg per kg, 2 ml subcut BID was given from day 1 to day 21 as analgesic. For the problem of hyperexia, B-complex 2 tabs per os were given twice a day from day 1 to day 21 as appetite stimulant. And for pyrexia due to suspected E. canis, doxycycline was started at 10 mg per kg per os SID from day 16 to day 21 as antiricaptile. For the foul-smelling unilateral ear discharge, Surolan ear drop was given PID for 2 days only at day 17 and day 18 for the treatment of otitis externa. So the prognosis for Hichen's case is good because the anal sacculitis wound is healing well, the pyrexia was resolved, as well as the bilateral ear discharge was also resolved. That's all from us. Thank you.
Any question? Right, so I have a question. I missed part of your presentation. So how do you explain the dog actually improved with doxycycline while 4DX results is negative for E-canis, I mean?
Good morning, doctor. For the 4DX test, it was done on day 3 of hospitalization. However, the pyrexia was started around day 11 of the hospitalization. There may be a infection during the hospitalization. We suspect it's an infection that started during the hospitalization. That's why the previous 4DX test may not have an infection at that point of time.
Did we repeat the blood between 21st to 25th October?
For blood to parasitology lab, it was done on Monday, 25th of October.
How about CBC?
Yes, CBC was done on Monday, 18th of October, and also repeat CBC on Monday on 25th of October. This is the result.
Oh, so why there's no count for thrombocyte? Sorry if I missed it from your presentation.
The result that came from the CP lab, it did not have a reading for thrombocyte because it says there's clump thrombocyte may also be due to the blood collection procedure.
So how long you're planning to give doxycycline?
If I'm not mistaken, we have only started for 1 week right now, and I think planning to continue for another week until the end of hospitalization.
What do you know about the treatment of ehrlichiosis? How long should doxycycline be given?
28 days.
Yeah, 28 days. So that's what you should say. You don't know. You're assuming that it's just going to be stopped after 1 week.
Uh,
Nobody's going to
twen-
do that. If you
28
suspect
days.
ehrlichiosis, you're going to give it for 28 days. I have one question, one correction. When you give differentials, it must be the disease, not the agent. So if you have, blood parasites, you've put in a broad category, you can't just put E. canis. It has to be ehrlichiosis or it has to be E. canis infection. And then you say we sent the blood for parasitology examination and to look for E. canis and babesiosis. Then you make a mistake there. You're talking about the agent. It should be E. canis and it should be Babesia species. Okay, don't get confused. The name of the disease is different from the agent. And a differential must always give the disease name. All right?
Okay, doctor, we will make a correction.
Right. So if no question, let's move on to the next case.
There are some questions in the chat box. Shall we reply in the chat instead?
Please reply it here.
For the question of Kirtana, can I know why cephalexin and metronidazole will continue after ASD should resistance towards this drug? If not mistaken, the culture throughout the hospitalization, there was no discharge found on the anal sacculitis wound, and the systemic bacterial infection also improves. So the result is suspected to may not be 100% true to the wound itself. There may be some form of contamination. So since there is still clinical improvement of the wound and also overall condition of the animal, so the cephalexin was continued. However, metronidazole was changed to doxycycline for the suspected E. canis.
Suspected ehrlichiosis.
Sorry. Suspected E. canis. Hi, did you check for daily PCV to check if the condition improved after doxy treatment? The PCV was not done. However, another blood test was done on Monday, 26th of October, 26th. No. Recently this week. The result was still anemia, which is at 29% PCV.
So for Naomi question, so what was given to treat anal sacculitis? So we can conclude that the wound is healing very well, might be due to topical antibiotic cream, which contain of gentamicin, and also maybe the effect from the cephalexin antibiotic as well. So we believe that these two antibiotics did play a role in helping of the wound healing.
There's no more questions, so we'll move to the next case. Thank you.
Morning, everyone. We are going to present about the management of chronic wound in the average cat. Ben is a DLH 9 years old congenital male weighing about 4.4 kg, which may age semi-normal with other cat. The vaccination and pneumonia is started. The history was the wound from the unknown cause at the fly, and the wound started getting bigger and not healing, and Ben was brought to different vet before, but there was no progression. But the latest vet was prescribed Ben with the Carbamol, and Carbamol was finished a day before presented to PH. And then this is the picture from the owner before the progression before it's getting bigger. The wound is about 3 to 2 centimeter and it's getting bigger, but the owner is not sure about the treatment. For open physical examination, then looks QAR, and then there was a open wound about 10 to 6 centimeter at the right blank region, and the ear also have a dirty wax and also flares. This is the picture that we kept from the doctor. At the front clinic, there was a moist open wound of approximately 10 to 6 centimeter at the right blank region with the peripherous cap and a slight leakage. From that, we come out with the differential diagnosis for chronic bleeding. The first one, it may be due to the bacteria such as mycobacterium, or actinides, or maybe due to the fungus such as porotrichosis or cryptococcosis. For the non-infectious, there could be due to the traumatic injury or tumors such as cutaneous lymphoma, muscle tumor, squamous cell carcinoma, or fibrosarcoma. For the underlying disease that cause a chronic wound bleed is maybe due to the FIV or EPLB. For the plan is we do TBC and serum biochemistry and SNAP FIV FPLB combo test. Next one we do cytology, bacteria culture, fungal culture, and lastly a punch biopsy. For the blood result, there was no significant finding except for the biochemistry. We could see hyperglycemia due to hyperglycemia, maybe the infection or inflammation. For the SNAP FIV and EPLB combo test, it was positive for FIV and negative for okay.
Alright, so upon presentation in the clinic, after the wound for Ben was clean, a sample was taken for cytology. So the results showed there was abundance of intact neutrophils, which suggests inflammation. And then there was also presence of a few fungal hyphae. And in addition to that, we could see a few mast cells at various stages of differentiation. However, there were too few of the cells for us to confirm a diagnosis, and hence this result is inconclusive. Okay, so 2 days later, while taking a sample for bacteria and fungal culture, another sample for cytology was also obtained. From this second sample result, we could see that there was blood with many neutrophils, plasma cells, some macrophages laden with siderophilic granules, and occasional hematoidin crystals. We could also see many round to spindle-shaped cells, and this is suggestive of mesenchymal cells. And also, we could also see the presence of fungal hyphae. So based on the morphology of the growth of the bacteria, the one that was suspected is either E. coli or Klebsiella. So however, the result from the identification of the bacteria is still pending. From the fungal culture, so far no growth were detected yet, so result is still considered as pending. So based from all the current findings, we can rule out bacterial infections such as the Mycobacterium, Rhodococcus, Nocardia, and the Actinomyces. And then we can also rule out the neoplasia cause such as the cutaneous lymphoma, ulcer tumor, squamous cell carcinoma, and the fibrosarcoma. And lastly, the FELV. So we have come to a tentative diagnosis of suspected colibacillosis or Klebsiella infection concurrent with the FIV.
Treatment plan for the chronic non-healing wound was wound cleaning SID using normal saline, diluted chlorhexidine, diluted iodine for day 1 until day 7 to prevent wound contamination. And wound scarifying was performed on day 4 and day 6 to promote tissue healing. Tramadol 3 mg per kg, 0.3 ml subcut BID on day 3 to day 4 as an analgesic. Papes 1 tab POBID on day 1 to day 2 as an anti-inflammatory, and Hijuven was given on day 3 to day 7 as a vitamin E skin supplement, and augmentin amoxicillin and clavulated acid 15 mg per kg 0.75 ml POBID was given on day 4 to day 7 as broad spectrum antibiotic. And for the inappetence problem, B complex 1 tab POBID was given on day 2 to day 7 as an appetite stimulant. So next. So for the progression on day 1 until day 7, the wound was clean, no peripheral scab or pus, but the size of the wound was remained the same, which is 10 times 6 cm. So the prognosis was fair because this wound was a chronic non-healing wound of a cat with FIV positive that usually will had a poor healing process. Furthermore, the wound was complicated with other bacterial infection that also contribute to the delayed healing process. So for the client education, due to the owner cost constraint, the owner decided to proceed the wound cleaning first at home. So the client education for the owner include daily wound cleaning by wearing gloves to prevent contamination of the wound, continue the medication at home, and wound scarifying once every 3 days, and plan to revisit in 2 weeks time for further plan for the wound closure, and keep the cats indoors and separated from other cats to prevent secondary pathogens or spread of the FIV among the other cats. So that's all for us. From us, thank you. Any question?
I have a question. Can you comment on the fungal hyphae that was found? Is that normal to be found in wounds because you didn't suspect that this is any fungal complication of fungal infection?
From what we discussed last night, is maybe due to contamination from the surrounding. We asked Professor they could be maybe it could be a
Can you speak
sporo.
louder? You're very soft and it's breaking up.
For the hyphae that we found on here, we suspect that the fungus could be contaminant from the environment.
Okay. And then I'm just wondering, once the bacterial infection has been addressed, are there any surgical options for this case?
Actually, Ben was scheduled to do a surgery for skin opposition by Dr. Maria, but after dia put the cytology result was come up for suspected mast cell tumor. So Dr. Maria decided not to do surgery for Ben, but it's not suspected as a MSC.
MCT, you mean?
MCT, sorry.
Okay, so in fact, it is possible to try. Would surgical opposition be possible? Is there like skin?
Yeah, still have, but I think I asked doctor, but it's quite hard to do, but it's possible.
What would be other options rather than just opposition of skin?
Uh, I don't think we have other than skin closure because it's the only way to close the wound because the wound is too big.
So the
What
only
about
option
graft?
are for skin flap.
What about a skin graft? If you don't know, you don't know. You can always find out, yeah? You can have a discussion with the surgeon and see.
Okay, all right, doctor.
Hi, morning. I have a question. Just now you mentioned that vitamin E is being supplemented. Could you please explain a little bit what do you know on how vitamin E promotes wound healing? You don't have to Google it. You should know by now. I can see your screen.
Yeah, that's why nowadays the students, there's such a delay once you ask a question to get an answer, because everything's being Googled.
CE is coming soon. Come on, vitamin E, year one.
For the question about ASD, actually we send it for culture and ASD, but the results still pending.
For Dr. Mukrish question, if I'm not mistaken, vitamin E helps to protect the cells from oxidation from free radicals. So it prevents further cell damage from oxidation.
I'm expecting a little bit more answer on that. I mean, there's a lot of reviews already available on vitamin E in promoting wound healing. We know vitamin E is an antioxidant. What else does it do? So it has something to do with cellular signaling. So you better read up, okay? Comprehensive exam is very near, very basic, so you need to know all this.
Okay, doctor.
So
Question.
for the question, in the chat box, in your opinion, what is the reason for the non-healing wound? So basically, the non-healing wound is because the primary cause is still not can be conclusive yet, but it can be difficult to healing because of the cat is a FIV positive. So basically, it will cause to the delayed wound healing.
For another question, which is, does laser therapy help in this to promote wound healing? For our opinion, yes, laser therapy can help in the wound healing because it will stimulate and activate the cell to promote growth and also propagation and repair. However, the main concern was the owner is cost constrained. That's why we doesn't suggest to do laser therapy to the owner.
Sorry, Fulton, yeah, we have some technical issue. We cannot turn off the presentation. Okay, so we'll move on to the next case from ICU.
Moving on to ICU case, we will be presenting about chest tube placement in a case of pyothorax in a domestic short hair cat. So meet Mani. Mani is a domestic short hair feline, 3 years old, spayed female with body condition score of 2.5 out of 5 and weighing 4 kg, and the management, vaccination and deworming was not stated. As for the history, the cat was presented on 28th of October. There was sudden onset of respiratory distress and sudden labor bleeding at night. And the cat was presented to UVH on the next day and was warded in ICU. Upon physical examination, the temperature was not taken and the animal appeared tachycardia and tachypnea. And there was pale pink mucous membrane, CRT 4 seconds and skin 10 3 seconds. And the animal showed respiratory distress with tachypnea and harsh lung sound. So we come up with problem list of tachypnea with dyspnea and harsh lung sound with differential diagnosis of pleural effusion that could be due to pyothorax and chylothorax. Pyothorax could be due to Rhodococcus equi, nocardia, actinomyces and fusobacterium. And next, it could be due to congestive heart failure such as HCM and RCM. And it could also be due to feline asthma. And the further plan is to do CBC and serum biochemistry, thoracic radiograph, ultrasound, thoracosynthesis, cytology, bacterial culture, and chest tube placement. As for the blood result, the hemogram showed no significant findings. As for the leukogram, there was leukocytosis with neutropenia and monocytosis that could be due to chronic inflammation or infection. As for the biochemistry, there was low creatinine that could be due to low muscle mass. So radiograph was taken on the first day of hospitalization. And we can see there was generalized increase in soft tissue opacity of the lung and obscure cardiac silhouette with radiological diagnosis of pleural effusion. And ultrasonography was also performed on the same day. And we can see increase in echogenicity at the pleural space indicating pleural effusion. And so thoracosynthesis was performed throughout the hospitalization of the animal daily. And next. So we can see full smelling, thick viscous opaque fluid consistent with pus which indicate pyothorax. It was aspirated from the right thoracic region and the fluid sample was sent for cytology and bacterial culture on the first day of hospitalization. Radiograph was also taken post-thoracosynthesis on the first day. And from the first day, we can see there was reduced in the soft tissue opacity at the left thoracic region. And it was after 168 ml of full smelling pyothorax fluid aspirated out. And this table showed the total of pyothorax aspirated from the day 1 of hospitalization to day 5 of hospitalization. And from the 29, we can aspirate 168 ml of pyothorax fluid. On 30 of October, we can aspirate 20 ml of pyothorax fluid. And 31 of October, we aspirated 216 ml of pyothorax fluid. And then on day 4 of hospitalization, we aspirate 155 ml of pyothorax fluid and chest tube was placed. And on 5th day, we aspirate 23 ml of pyothorax fluid and we perform pleural flushing with 250 ml warm normal saline TID. And this showed the radiograph on the second day of hospitalization. And we can see from the before and after the thoracosynthesis, which is 20 ml of pyothorax fluid aspirated out, the radiograph remained the same in the soft tissue opacity because the fluid keeps on reaccumulate. Next, from the lateral radiograph, we also can see there was no improvement as the fluid keeps on reaccumulating after 20 ml of fluid aspirated out. And for the radiograph on the third day, we can see increase in soft tissue opacity and especially at the right region. And on that day, 260 ml of pyothorax fluid was aspirated out. Also on the lateral radiograph, we can see the pyothorax fluid keeps on reaccumulating again, even after thoracosynthesis.
So on the fourth day of hospitalization, chest tube placement was performed, which because to reduce the multiple thoracosynthesis due to the recurrence of pyothorax. So before the placement of the chest tube, the cat initially managed with oxygen supplementation and immediate thoracosynthesis to allow the re-expansion of the lungs. And then the cat was pre-medicated with atropine 0.04 mg per kg IV and being induced and maintained with propofol 1 mg per kg IV. This image shows that the cat was pre-oxygenated for 5 minutes. Then the cat was intubated with size 3 EDTT tube. And then the cat was placed on the left recumbency. And then the right thoracic region was shaved and aseptically prepared. Then the length of the tube to be inserted into the chest cavity actually was measured by using the radiograph, where the length
of the placement of the tube was measured between the skin incision, which is at the 10 intercostal space, and through the apex of the lung to estimate how far the chest tube should be inserted. So in this case, it's about 17 centimeter. Then drape was placed and 10 intercostal space was identified. Then small incision about 0.5 centimeter was made at 10 intercostal space. The distance between the 10 intercostal space to 8 intercostal space was measured and marked. And then tunnel was made by blind dissection, the subcutaneous from the 10 intercostal space to 8 intercostal space by using Kelvin forceps. And then the chest tube was inserted. So the chest tube was advanced into the pleural cavity by using the Kelvin forceps through the 8 intercostal muscle. After that, sterile chest tube was advanced into the chest cavity until the previous measured mark on the tube. Then the chest tube was secured by finger trap suture. And then any remaining air was aspirated from the pleural cavity and three-way stopper was connected to the end of the chest tube. After that, post-chest tube placement assessment by using radiograph was performed, and we can see that the tube actually inserted from the 10 intercostal space and going through the apex of the lung. However, from this radiograph, we can see the tube actually forming a band at the cranial thoracic region. And this showed that the tube actually was advanced too much. So we worried that the tube will forming king and obstruct the fluid flowing. So the test tube actually was adjusted by pulling out about 4 centimeter. And then another radiograph was taken to evaluate the placement of the chest tube. Next slide. This was the assessment of the post-chest tube adjustment. That's all from us. Thank you. Any question?
So there's a question in chat box.
How long will the chest tube will be maintained in this cat? So based on my reading, the tube actually can be maintained up to 4 days. However, if the pyothorax still not resolved, can actually still maintain the chest tube. However, we have to ensure the cleanliness of the chest tube and to prevent any contamination and during the handling of the chest tube, we have to ensure there is no air enter and causing the pneumothorax to the cat. For the even question, how to do the thoracosynthesis in this cat? So the procedure is like the chest tube. However, we used initially the cat was sedated and put on the sternal recumbency and skin form, and then the thoracentesis was used the butterfly catheter that we actually insert between the ribs number 7 and 9 because we want to avoid puncturing the heart and abdominal organ. And then after that, three-way stoppers was connected by using 20 ml shrink. So we aspirate out the fluid from the pleural cavity. So actually, there is no maximum amount to aspirate. We have to just aspirate until there is no fluid aspirated out and there is a negative pressure. For Sharlina question, in this case, will the negative pressure of the thoracic cavity in the cat be compromised, and how can we assist the cat in that case? So because we placed the chest tube, so the chance to accidentally introducing air into the chest cavity and cause the reduction in negative pressure is there. So we have to aspirate out the air until we can feel the negative pressure back. And then we have to assess through the radiograph to see if there is any pneumothorax at the chest cavity. So if the cat, we see the cat having the mouth breathing or labored breathing, can actually immediately transfer the cat into the oxygen cage and supply with 3 liters of oxygen.
Any more question? This is a pyothorax case, right? Did we send sample for bacteria identification and AST?
Yes, doctor. The fluid was sent. Yes, the fluid was sent on the first day of presentation for the bacterial culture, cytology, and AST. However, the result not coming back. However, when we called the bacteria lab yesterday, so they said that the suspect is actually Pseudomonas because of the smell. However, they are not confirming it yet. So they said that the latest is by this Friday for the result to come out.
So do you manage to read about Pseudomonas causing pyothorax in cats?
Actually, in this case, the cat was suspected with Rhodococcus. For the Pseudomonas, is actually one of the common bacteria that can causing the pyothorax in the cat too.
Yeah, so that's a point, when you see a case, then you have to start looking at the literature, look at the most common causes for pyothorax, and then you could start investigating or looking at, how common they are, what are the specific treatment, and whether they have good prognosis or recovery. So that's how you learn. Okay, so it's kind of difficult to get extra information just based on, the way VO handled the case. So you have to complement that with your reading as well. Right, any more question, Dr. Malika?
No, I'm good.
Okay, right. So, well, I think that's it. So we'll end the round. Thank you very much.
Thank you, doctors.
Thank you, Doctor.